Good morning. My name is Saraswati Vedam. I'm a professor of midwifery at the University of British Columbia, and I'm coming to you today from the traditional and unceded lands of the Squamish, Tsleil-Waututh, and Musqueam nations of Western Canada. I'm going to tell you today, I'm joined by Ariane Metalis. We are going to tell you today about some research that we have collaborated on and help you to understand how we've approached health equity measurement through a participatory action research. I'm just going to pause and share my screen. Ariane, perhaps you'll tell our listeners who you are and how you've come to this work with us.
Yes, thank you for having me. I'm a reproductive health advocate. I'm a service user sitting on the steering council of this research, and a regional recruitment coordinator for the province of Quebec here.
So she comes from the traditional and unceded territory of the Kanien'kehá:ka and Anishinaabe nations, and we want to acknowledge them. And I'm grateful to be doing this research together on those lands as a guest. Our work is funded by a number of sources, and we're grateful for that funding. We have no conflicts to declare. In order to have credible, usable data, we need to ask the right questions in the right way and the right people. Most people will focus on how to ask enough people. They feel that having big numbers will give you that kind of credible research. But we believe we have to start first with asking the right questions. In order to do that, our participative research always starts by creating a multi-stakeholder team that includes service users at the center of the research. So they help us to identify what to study, seek the funding for that, co-create the study tools. They help us through recruitment, through interpreting the data that we collect, identifying the key messages, and they help us create the tools that share and tell the story that we've been engaged in. With the RESPECT study, it's a Canadian study that's supported by the Canadian Institute of Health Research. It is national, and we have a focus on those voices who've been seldom heard in perinatal research, those people with various identities, circumstances, and backgrounds that have left them outside the conversation. We started with convening a steering council of service users to be the decision makers all the way through this process. We also invited people who were clinicians and service users, people who were had worked with the service users that we were particularly trying to elevate the voices of. So NGOs, community health workers, researchers in Indigenous health, people who are clinicians or maybe mental health workers or sociologists. And together we co-designed the plan, and a plan for how to make sure that the lived experience was carried through all the way the analysis and interpretation phases of the research. The community members chose the topics. They said they wanted to study access to models of care, experiences with pregnancy and birth care, decision-making, respect and autonomy, respect broadly defined so both respect and disrespect, racism, mistreatment, consent, non-consent, but also what builds health and well-being. Ariane joined us when we were starting to to build the survey instrument where we were selecting the measures. Ariane, would you like to tell them about your experience?
Yes, so I joined the team in early 2019. The global scan was already done by the research team. So we had to, sorry about that. Maybe you hear some noise, the kids in the background. This is what it looks like to have service users working from home in this kind of research. So in the Delphi process, we had to evaluate the questions, the items, decide we had to rate them, what was the importance, the relevance, and the clarity of them, how we understood them as community members. how we wanted them to be asked to our communities. There was a number of them. They came up with 210 about. We had to prioritize them to even lessen the number of items because it was way too long to get that to participants. We also had to make it, how can I say that? To adapt it into a regional context. I'm from Quebec. Let's say, for example, the midwifery accessibility is not the same as in the rest of Canada. So we had to accommodate those questions around regional contexts.
Yeah, the steering council had a number of people who had lived experience from different types of backgrounds and different regions. And so together they represented what the experience of pregnancy and childbirth care looked like across Canada. And the researchers, when they were involved in the Delphi process, used a very quantitative way to come to agreement about what were the most important things to ask in Canada. And we had an interesting experience. Ariane, maybe you can share with them about that. I remember that the researchers who were involved said, well, it's not so, among all of the items, they were had to make difficult decisions about what to keep and what to let go. And at one point they said, well, we don't really have to ask about forced sterilization. That doesn't happen here in Canada. And what happened, Ariane?
So yeah, we as service users thought it was very important to ask, because I think that's an example of as a lived experience. I haven't been sterilized by force, but I've heard of it numerous times. So I can say for a fact that yes, it did happen, and yes, it is happening.
Yeah, the Indigenous service users on the steering council were very clear that that was something that had to remain and be prioritized.
Yes, definitely. So that's an example of how important the service users' voices are important on this project.
Thank you. So ultimately, we came up with the service users also told us that it was important not just to measure the negative experiences, but also what could make things better. So for example, they said it was important to measure whether or not they were able to keep their cultural traditions, whether or not they could have their families with them. And that when we talked about disrespect and abuse, that we needed to describe what does that look like. So a healthcare worker or other staff threatened that if you did not comply, you or your baby would have a poor outcome. This has been actually reported globally, and apparently was also really important to service users here in Canada. So we found the validated item and we adapted it for the survey. And then we got into recruitment, and Ariane was very involved in that. She was a steering council member and then also became a regional recruitment coordinator. And we had a number of meetings with our regional recruitment coordinators who are all over Canada, 18 of them. And we decided together what we had to focus on. So Ariane, perhaps you can describe what the regional recruitment coordinators and steering council felt was most important to focus on.
Yeah. So I think most importantly, the goal is yes to measure respect in maternity care, but is also to meet the needs of historically excluded communities, racialized immigrants, rural, remote, and homeless people. So at the beginning, one thing we wanted to do to recruit was to have survey cafes, meet with NGOs, have clinic recruitment, have data doulas and translations, many translations of the survey in different languages. Everything changed when COVID hit, where we had to rely solely for a long period of time on on the internet, so on social media, emails, contact with people by email, via phone. But because of COVID, a lot of places were closed. So no more survey cafes, no more data doulas. The translation process was a bit slow at one point. So it did affect our ability to build trust with participants, with accessing the survey. So the way we wanted to do is to meet people, but now having to rely on the internet, a lot of people didn't have access to internet. People who lived remotely or in rural places where there's not no connectivity, but less maybe, or a less quality of. It also came to, we need more regional recruiters with lived experiences to be able to build that trust with participants, with community resources. And not only COVID, but then came the Black Lives Matter, well, everything that happened around like George Floyd's murder, the discovery of, up to the discovery of unmarked graves of Indigenous children here in Canada. Not only, it didn't affect only the participants, but it did affect all of us being involved in this big project. Our not engagement, I was going to say productivity, but in our engagement was affected by all this. Yes, because of everything that was happening in this society, also because we had to, how do you say that? Prolong we the deadlines that we had before. We had to push them to, like, let's say for the recruitment, now it's ongoing until December 2021.
Yeah, I think that was a result of the ongoing community. We, as a research team in a multi-stakeholder team, we were constantly having these conversations and trying to reshift and figure out how could we be both. We asked actually, should we stop? Should we just go with what we have so far? But the service users felt very strongly that they felt it was they wanted to continue. They just wanted to have extend the deadline, extend the data collection period to give people more time to engage with it over time. So we shifted the timeline, we changed our modes of collection, we changed our graphics to try and make it more accessible. And then most recently, we created a shorter form. And that was really, Ariane helped us with that too, to figure out what was most important to retain. We knew that we'd have to have other ways to make it accessible. If everything was going to be online, we had to create a screen reader version for people who were sight impaired, closed captions for people who might want to tell their the deaf community about it. So we learned a lot through the process about authentic and respectful community engagement, I would say.
Yes, definitely. Definitely.
So I'm going to close by saying that when you work with service users, they may look at it differently. They may say, instead of measuring and looking at all the deficits, let's look at what makes people healthy. Let's measure undisturbed birth rates. Let's measure respect, disrespect, the impact of model of care, and the impact of things like racism and bias on care, so we can change and improve quality of care. That's what we mean by co-creation of anti-oppression health systems. Thank you very much.
Thank you.
Ariane, can you help us close here by telling us what it what it means to you to be involved in this type of research about lived experience and your lived experience?
I think what's been important to me as a service user, not only to say that research is very important, is my engagement is that in that research as a service user, as being dehumanized and disempowered in the healthcare system for so long. It gives us that empowerment, that authority. It gives us back that empowerment and authority on not only my experience, but the future generations' experiences in the healthcare system, and how I'm contributing and how my voice is being heard through those kind of projects. So I would say that's my lived experience as a participant.
We're so grateful to have you and have your leadership and voice and insight. So thanks very much. All right.
Thank you.
Yeah, bye-bye.